Veterinary medicine is a messy business both physically and emotionally. Vetsplaining is one veterinarian's attempt to explain and understand her own profession a little better. Join Dr. Lisa McFadden as she delves deep into the medical and business aspects of veterinary medicine.
Simply put, pain sucks. Nobody likes hurting themselves. I, in particular, do not enjoy hurting myself, and I'm pretty sure I'm one of those people that has a fairly low pain tolerance. I'm also one of those people where when I injure myself, I really don't want anyone to talk to me until I've had a chance to stop being in pain and kind of process what happened, because usually what happens is someone says, "Are you okay?" And then I'm just so irritated and embarrassed that I hurt myself that I can't formulate words, and then that becomes more irritating, and it's just this whole cycle. So if you happen to know me and you're ever around me and I hurt myself, just ignore me until I start talking. Pain, unfortunately, is something that does routinely affect both our canine and feline patients. And one key thing to keep in mind is the way that our dog and cat patients respond to pain is different than the way people respond. Common signs of pain in people are grimacing, frowning, writhing, shifting, moaning, groaning, whimpering, cussing should be on there, complaining, being angry, irritable, restless, or agitated. Most dogs, though, tend to retreat into themselves. They can become antisocial. They may have aggressive behavior. There may be changes in eating, drinking, and sleeping. Some may have excessive vocalization. Some whimper, but that's honestly not as common. You can see excessive grooming, panting, altered breathing. You may see mobility issues. And one thing I frequently get from clients is, well, I know he's limping, but he doesn't seem to be in pain. 9 times out of 10, if they're limping, it's because they're in pain. They have changed their gait to avoid discomfort, and discomfort is a form of pain. Other signs you may see are agitation or irritability. You can see changes in body posture. Sometimes dogs will hold their tail down. Other times they'll hold their ears either pinned back or really close to their head if they have floppy ears. Cats often hide. They might just sit still or sit very hunched. They may have a loss of interest in people, pets, or activities. You may notice over-grooming or even under-grooming. Sometimes they purr excessively or they meow excessively. One way to kind of think about that is a lot of cats that I examine at the veterinary hospital purr during the entire exam. And it's not because they're like super excited to be there and yay, I love this. It's because they're uncomfortable and nervous, and it's kind of like people that have like a nervous laugh or a nervous tick. Cats may also have unusual vocalizations. Usually if a cat's yowling because of pain, it's really serious. You may also notice inappropriate urination or defecation, and sometimes aggression. Pain is actually a hot topic in veterinary medicine right now, and we're actually considering it the 5th vital sign. So our vital signs typically are temperature, pulse, respiration, frequently mucous membrane color, and what's called capillary refill time. It's kind of like if you go to the doctor and they push on your fingernail and they watch for it to blanch and then pink up. We do it usually on the gums. And then pain is considered that 5th sign. Some consider, instead of the mucous membrane color and CRT, they consider blood pressure part of those 5 vital signs. Pain is actually a very complex topic, and a lot of people think of pain as acute versus chronic, and so they only really refer to a difference in the length of time that the condition exists. But realistically, those are the same thing. Instead, we should talk about what we call adaptive and maladaptive pain. Adaptive pain serves a biological purpose. It's there to tell an individual that there is either an actual or a potential tissue damage. So there is either a true issue or will be a true issue, and we most frequently see that with trauma, surgery, or other medical problems. And generally that pain goes away once the underlying condition resolves. It is often acute in nature, and it indicates that the nervous system is functioning appropriately. We also call that nociceptive or physiologic pain. And again, it's a direct result of minimal tissue injury that is secondary to inflammation, and it provides a warning to that particular organism that there is trauma, that there is local damage. And usually that pain is also well localized. This is a crucial protective physiologic reflex. It allows avoidance of pain. Without it, we would just continue to injure ourselves because we wouldn't recognize that it hurts. Maladaptive pain basically occurs because the central nervous system went off the rails and went haywire. It is actually pain that really should not exist. There's a few terms we should think of when we're talking about maladaptive pain. One is the idea of neuropathic pain. So this is pain that it develops because of a nerve injury, whether that's within the spinal cord or outside of the spinal cord. And you can also have what's called wind-up pain. And in those cases, it gets a little technical, but basically what are called the NMDA receptors, which stands for N-methyl D-aspartate, in the dorsal horn of the spinal cord, which is one portion of the spinal cord, they cause a continued pain response. Another term that you may hear is facilitation, and these are spinal lesions that cause afferent signals, signals going to the brain, to overwhelm that portion of the spinal cord segment. And what it does is it lowers the threshold of nerve firing. And every nerve has a threshold amount of signal that's required to get that nerve to fire, to get it to do its job. And when you lower the threshold, what you're doing is you're allowing that nerve to be hyperexcitable. So even the smallest sensation can cause that nerve to fire. And when it fires inappropriately, you then get pain responses due to what are considered generally benign stimuli. And the excessive nerve firing then causes other changes such as vasoconstriction or narrowing of blood vessels, muscle hypoxia, so decreased oxygen to the muscle, local tenderness, trigger points, spasming of muscles associated with the spinal column. And then this becomes like a perpetuating cycle. And you then have the concept of inflammation causes further neuronal facilitation, right, which was the fancy word we used at the beginning of this, that causes muscle changes, that causes pain, that causes more inflammation. And you basically get like pain begets pain. And so the idea of wind-up pain is really kind of like a colloquial expression that is trying to sum up what happens when you have facilitation. And so in neuropathic pain, in maladaptive pain, the problem usually is gone, but the pain is still there. And then you also get, because of everything we just talked about, non-painful stimuli causing painful stimuli. So these are the people that, it's like you touch them lightly and they writhe in pain. Or sometimes if you have cats that have irritation, anywhere you touch them, they're going to scream in pain. So we know our two main types of pain. Now we have to think about how we manage it. And some veterinarians are kind of coming up with what they call like a 3-step process. Step 1, control the pain. That makes sense, right? We don't like pain. Pain is not helpful. So basically, physiologically, patients are going to have better outcomes and quality of life if we stop the pain. We also have a moral and ethical reason to stop the pain because, again, that veterinary oath I like to bring up, do no harm. Pain also causes a stress response, and stress can be healthy and it can be normal, but chronic stress can be very negative to the body. And you can have lots of proteins and hormones that go haywire. You can have reduction in your ability of your insulin to work. You can have reduction in testosterone. You can have a decreased immune system. You can have decreased gut motility, which leads for the potential of infections, because if your gut's not moving, the bacteria that is inside of your gut can potentially migrate out of the gut into the bloodstream or into other areas of the body. You can get retention of sodium or basically salt inside of your body, which then leads to retention of water. And if you have pre-existing heart disease, it can cause worsening of your heart disease. You can have reduction in the amount of oxygen you get to your body and how well you ventilate, how well you're breathing. And it can also reduce your ability to heal. So as you can see, controlling pain, very important. The second step is we need to plan for prolonged pain control because, again, as we talked about, you have that adaptive pain, we had a trauma, we have pain, we fix the trauma, the pain goes away, then you have that maladaptive pain. We want to avoid that maladaptive pain because lapses in pain control lead to wind-up pain, and wind-up pain is harder to control than that initial pain response. The third step is multimodal. So this basically means we use multiple forms of therapy to achieve an effect. And based on that brief but probably overwhelming description of facilitation, you can see there's a lot of complex factors that are involved in pain, from the initial trigger to how the brain interprets it to then how the body responds to it. And by using a multimodal approach, we can affect change throughout that mechanism. So we can help in different areas to reduce the chance of wind-up pain and to help with animal comfort. So we're going to go through kind of in brief detail each of these categories, and some of these we'll actually talk about in later podcasts. So I didn't want to make this podcast too long, so we'll be hopefully efficient. So NSAIDs are the first category to start with. That stands for non-steroidal anti-inflammatory drugs. And really what they are meant to do is set them apart from steroids. So our classic steroids are things like prednisone. That's the kind of the typical one we think of that we take orally. And NSAIDs can be used in an emergency, i.e. acute setting, or they can also be used in chronic pain settings. The most common class of NSAIDs that we use are called COX-2 inhibitors. And cyclooxygenase, or COX, is this whole propagation of inflammation, and it's this whole cascade. Just like with pain, the cascade of events that occur with inflammation is also, in my opinion, unnecessarily complicated. But basically, you have this category of drugs called COX-2 inhibitors that help reduce inflammation within the joint, but because they have effects with COX-2 in other areas, they can also cause issues with liver or kidneys or gut. So the primary COX-2 inhibitors that we use are carprofen, which its trade name is Rimadyl, meloxicam, also known as Metacam, and robenacoxib, which is also known as Onsior. Cats are tricky just because, in my opinion, they're half alien, and they're hard to treat with NSAIDs. Metacam we used to use a lot, but then it got what's called a black box warning, which basically means like don't touch it, because it has been associated with kidney disease in cats. That being said, I used to manage a fair number of cats in kidney failure who had arthritis with Metacam. You just have to know how to use it, but because it has that black box label, it's kind of like untouchable, and veterinarians, as a general rule, don't like to do things that are going to get them sued. So Onsior is a anti-inflammatory that we can use in cats, but the problem is that it's only labeled for 3 days post-operatively. So it's really only labeled to be used in cats for 3 days after they have surgery. Doesn't mean we can't use it off-label, but we just have to be honest with clients that this is an off-label use. It is effective, but because it's a drug that was approved by the FDA, and the FDA says this is what you're supposed to use it for, I need to inform you that we are not using it in the direction that the FDA recommended. All COX-2 inhibitors have potential side effects, and the most common are gut issues, vomiting, diarrhea, and even potentially the formation of an ulcer in the intestinal tract. They can also cause liver and kidney enzyme elevations. Usually we do monitor blood work fairly closely when animals are on anti-inflammatories long term. In an ideal situation, we get blood work pre-starting it. We get blood work about 2 weeks in or a month in, depending on the veterinarian, and then we get it again at 3 months, and then we do it every 6 months. And this is just a way to make sure that by helping the musculoskeletal system, we are not also hurting another organ like the liver or the kidneys. There's a newer anti-inflammatory called Galaprant, which is actually a prostaglandin E2 or a PGE2 EP4 receptor antagonist. So it's a non-COX inhibiting NSAID. So it's not supposed to, in theory, have the potential negative effects of kidney, liver, GI. That being said, the most common side effects you see with Galaprant are vomiting and diarrhea and decreased appetite. We still do recommend the same amount of monitoring, but in the long run, they're supposed to be a little bit easier on the system than your traditional NSAIDs. It does, in my opinion, take about 2 weeks before you see the full effect of the Galaprant. So sometimes it can be a little frustrating for clients if they're expecting that like immediate response that you usually will see with things like Rimadyl, Metacam, Onsior. But for dogs that have changes to their kidney and liver or cannot tolerate those other drugs, it's a great addition to our pharmacy. The next category of medications are called opioids. So these are your true pain medications. In people, we think about things like codeine, morphine. In animals, we use tramadol, which is an oral opioid medication. We use buprenorphine, which can be oral or injectable, and we can use fentanyl patches. The downside with opioids is they do not reduce inflammation. And there's also a lot of stigma with them right now because of the whole opioid crisis. Animals, as a general rule, do not get addicted to opioids like people do, in part because they cannot tell us they're addicted. And, you know, your dog would never, like, sell your car to get more tramadol just because he physically cannot. And it is possible that dogs that are on things like tramadol long-term can actually have withdrawal signs when you take them off. I have personally never seen it. But because of the heightened regulations with controlled substance monitoring, some veterinarians are shying away from using opioids as much. I think there is a place for opioids, but to be honest, I think that in the past we